Welcome back to the Masterclass, everyone. I'm your lead instructor, Harshal, and today we're diving into part 104 of our Explainer series. We're tackling an advanced deep dive into major diagnostic category 14, specifically deliveries and obstetric operating room procedures. So grab your notes, because a single code change here can literally mean the difference between a clean claim and a massive audit headache. But real quick, before we jump in, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is what helps us keep this masterclass completely free. All right, here's our roadmap for today. We're going to breeze through the MDC-14 hierarchy, hit those high-volume DRGs, dial in our PCS precision, and then wrap things up with a teaser for next time. So, Section 1, MDC-14 hierarchy. Let's get right into the foundational architecture of the MSDRG system and see how surgical procedures completely dictate grouping. Now, you might remember in Part 103, we covered standard, uncomplicated medical deliveries. Well, today is all about the ultimate trump card, operating room procedures. When a procedure hits that CMS definition of a major OR procedure, boom, it yanks the case right out of the medical partition and drops it straight into a surgical DRG. And that shift fundamentally changes the reimbursement game for the hospital. Once you land in that surgical partition, what actually drives your payment tier? It really boils down to three main triggers. We're looking at concomitant sterilization, think tubal ligation right after delivery, secondary CC or MCC status, and surgical complication interventions. Spot just one of these, and your entire DRG pathway shifts completely. Moving right along to Section 2, high-volume DRGs. Let's look at the bread and butter obstetric cases you're going to encounter every single day. Visually mapping these out is super helpful. It instantly shows us how C-sections split off depending on the clinical documentation. For instance, a C-section has entirely different DRG families if a tubal ligation happens at the same time. Then you layer on the severity, no CCs, a CC, or a major CC. The whole reimbursement landscape literally transforms based purely on how precise the coder is. But here is a wild twist. Even a natural vaginal delivery can absolutely skyrocket into a surgical DRG if it brings along a major OR procedure. We're talking about interventions like a DNC for a retained placenta, a bilateral tubal ligation, or an operating room repair of a severe 3rd or 4th degree laceration. So the birth itself was medical, but the intervention, that flips the surgical switch. And this CC and MCC logic, it acts like a massive multiplier effect. Say a patient experiences a severe complication, right? Maybe a ruptured uterus or a placenta accreta spectrum. Accurately documenting that as a major CC proves the immense clinical resources the hospital had to deploy. It drastically pumps up that relative weight and the resulting payment tier. Now, beyond actual childbirth, MDC-14 also encompasses some really high acuity postpartum and post-abortion scenarios. Think about the surgical management of an incomplete abortion, using uterine artery embolization for severe postpartum hemorrhage, or a laparoscopic salpinectomy for an ectopic pregnancy. These are emergency situations requiring incredibly sharp, precise coding to capture their true complexity. All right, Section 3, PCS, Precision and Compliance. Let's zoom in from the macro DRG level down to the granular code building. Look closely at the official PCS guidelines for a second. The term delivery is super strict. It only applies to a manually assisted vaginal birth. The actual definition is literally assisting the passage of the products of conception from the genital canal. No cutting, no mechanical pulling, just pure manual assistance. So if you take away nothing else today, memorize this coding mantra. A cesarean section is always an extraction. It is never a delivery. Why? Because the root operation extraction literally means pulling or stripping out a body part using force. Since a C-section extracts the baby via a surgical incision, extraction is absolutely the only correct root operation. Here's something that trips up coders all the time: multi-section coding rules. The trick is knowing exactly what you're working on. When you're pulling the baby, you're working on the products of conception. That puts you in Section 10 of your PCS book. But let's say the surgeon also does a tubal ligation. Now you're working on the maternal organs. That jumps you all the way over to Section OU for the female reproductive system, using root operations like occlusion or resection. Same patient, same surgery, totally different body systems. Crazy, right? And remember, building a complete obstetrics code is like putting together a 7-piece puzzle. It's got to be exact.
Character 1 is always a 1 for obstetrics. Character 2 is a 0 for the pregnancy body system. Then you've got your root operation, body part, approach, device, and your qualifier. If the physician's operative note misses the details for even one of those characters, the whole code falls apart.
Take that C-section extraction we were just talking about. Your 7th character qualifier actually has to specify the exact type of incision. You can't just slap a generic C-section code on it. You got to be a detective. You read that op report and ask, did the surgeon make a classical incision? Well, that's a 0. Was it a low cervical cut? That's a 1. You have to hunt down those details. But PCS precision is only half the battle. It goes hand in hand with diagnosis precision. Capturing those high-yield secondary diagnoses, like placenta accreta, severe uterine atony, or an amniotic fluid embolism, totally alters the clinical severity profile. Remember our golden rule here. If a condition like sepsis is present on admission and is the main driver of that admission, it can fundamentally rewrite the entire DRG grouping. So what does this all mean when the rubber meets the road? Specifically, when a payer audits you? How do you defend your revenue integrity when an insurance company suddenly questions whether a procedure was even necessary? If a payer audits a high-weighted DRG for a non-elective cesarean, your documentation can't just be okay. It has to be absolutely ironclad. Well, here is how you build a bulletproof defense using a rigorous clinical documentation integrity review. It's a 3-step process. Step 1, validate the clinical necessity, like having rock-solid documentation of fetal distress. Step 2, double-check that the coder nailed the exact correct root operation. Was it extraction or delivery? Get it right. And step 3, make sure any post-delivery complications are explicitly, clearly linked to the interventions that followed. Now that is true defensible coding. Okay, moving into our final stretch, Section 4, Summary, and our next lesson teaser. Let's wrap up today's deep dive. To summarize, we've successfully navigated the MDC-14 surgical partitioning logic, and we saw exactly how OR procedures just completely override those medical DRGs. We've conquered the extraction versus delivery route operations in PCS Section 10, and we laid down some serious compliance strategies for linking clinical documentation to those crucial secondary diagnoses.
Before we go, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal.
Now, I want to leave you with one final provocative question. Once that surgical delivery is in the books and the mother's DRG is completely locked in, what happens to the DRG logic when the newborn needs immediate intensive care? Chew on that for a bit. We're going to crack that code in Part 105 when we dive into MDC-15, newborns and other neonates. I will see you in the next lesson.